Hello and good evening to everyone, or morning or afternoon, wherever you are in the world. Today, I have a midweek presentation, which is a little bit unusual because of the fact that I usually do a Saturday. But today, largely because I have my conference coming up on Saturday, and if you are not yet coming to that, that is about upper airway strategies for COVID-19. It's well worth a little listen, over 1,500 attendees so far, so look out for that. But today, I have got with me two people to discuss some of the strategies that we can use in an outpatient setting for the Delta variant. We're dealing with a different beast here, I think, and based on the experience with India and the fact that we're having spread in different parts of the world, it is extremely important for us to have contingency plans. And here today, I have the pleasure of having with me Dr. Chetty from South Africa and Dr. Carlette Norwood-Williams from the USA. Thank you guys for joining me today. Now, I'm going to start with you, Carlette. I want you to tell us a quick introduction about yourself, and then I'll go on to Shankara.
Sure. Thank you, Dr. Phillip. I've been in pharmacy a little over 30 years, and on both inpatient and outpatient practice, and I'm grateful to be here. COVID took the world by storm. It did the same with our little group, and what we pursued was an effort to manage the symptoms of COVID until we could access remdesivir. We were on the waiting list like the rest of the world for Gilead to release remdesivir as compassionate use. But of course, the priority was to those areas that had more significant population impact due to COVID. So my perspective was, let's work with what we have for now. And what we had on hand were medications to address pulmonary dysfunction. Medication.
So before you go into it, Carlette, because we're going to go into it in detail, let me just get Shankara in, and I'll get him to position what he does, and then we're going to come back and know exactly what you have done.
Absolutely.
So Shankara, tell us a quick bit about yourself, especially with regards to your specific research on the principle of the 8th day.
Hi, Philip. Hi to your viewers. I'm a general practitioner in South Africa. I've been practicing medicine now for the past 20 years. I'm also a natural science biologist. Have a degree in biology and genetics, with sub-majors in in microbiology and biochemistry. My whole aim with treating COVID was to understand the pathogenesis of this illness and to treat it appropriately. So I've been through now well over 4,000 patients, and I've had some consistent results, some consistent clinical improvements, which have lent credence to my understanding of the disease process. And I think that can have some great benefit in all settings of coronavirus.
Wonderful. And we're going to come back to that in a minute. So before we go any further, Carlette, because what we want to hear from is your work and your perspective in the US as to what you guys found.
Certainly. We found that if you combined particular medications at specific doses by drug class, that we could arrest the progression of COVID infection. And if we could prevent further decline in pulmonary dysfunction, then there would not be a need to require mechanical ventilation. In the outpatient setting, the same would hold true. If you could prevent pulmonary decline, the severe coughing and the effort to capture breath that seems to be unable to be captured, then you could prevent the need for hospitalization. So that's been the primary focus, to prevent the gasping. And so when you hear about a patient with asthma COPD, let's talk about life before COVID. Before COVID, if there was pulmonary dysfunction, bronchospasm, steroid is a standard used drug. It's not that big of a deal. We've been using short bursts of steroid for bronchospasm for decades. The challenge, however, is in the presence of viral infection. Very well known. All steroids have immunosuppressant side effects.
Mhm.
So the worst case scenario is you give someone a steroid to help them breathe better because the cough syrup isn't working outpatient. But in the case of a viral infection, you've just now given that viral infection an avenue for explosive expansion within the body because you've now suppressed the immune system with the introduction of a steroid in the infectious environment. So how do you combat that? Well, the alternate would be you provide the steroid to support breathing, but you cover the side effect concern with the immune support. So just as if a patient is prescribed a loop diuretic, for instance, very standard that if they're prescribed a loop diuretic, the physician automatically prescribes a potassium supplement because all loop diuretics deplete potassium. So in this case, in the presence of a viral infection, if you're prescribing a steroid to address pulmonary dysfunction, you had better have the wisdom to also order immune support to supplement that side effect that's going to impact the patient. Specifically, we've seen great outcomes with ascorbic acid, with zinc sulfate, and with cholecalciferol as well, or vitamin D. The next challenge, of course, was the risk of hypercoagulability. And so to prevent that, we would automatically get the patient on an anticoagulant. And so as long as we, let me pause, 2020, we knew that if we could have access to the patient between day 7 and day 10, recovery would be obvious by day 3. However, in 2021, it seems that the cases are so much more severe. The infections seem to move much more rapidly. And so it has appeared that we need a much earlier onset of this combination strategy.
So that's an interesting point, Carlette. So let's just dig into that a little bit, because this is critically about where we are now. What kind of differences are you noticing between 2020 patients presenting and 2021?
Well, to be fair, I've not seen even half of the 4,000 that Dr. Shankara has seen in South Africa. So I want to be very careful not to apply a broad-based observation.
Yes.
But specifically, it seems that if the initial complaint is a severe tension headache, if you will, and a mild tickle in the throat, as if you look at a patient complaint. Before, we didn't see patients until they had coughing and runny nose and fever. And they had a COVID positive test maybe 5 to 7 days before that. They tested because someone in the family was already positive. Many people were not even sick when they went and received a COVID test, but they began to show symptoms, undeniable symptoms, within 7 days, 5 to 7 days of that original test. Now, people are feeling the mild headache and the tickle in the throat, and they have full-blown symptoms by day 3. They have a full-blown cough, fever, and all of the other complaints, and they're saying, oh, I was just around someone 2 to 3 days ago. I haven't had my test yet. I'm going to go and get my test. And now you can get your test in 45 minutes to an hour. You can get your results much more quickly.
Just hang on a second with that, Carlette. Have you seen any patterns like that, Shankara? Anything similar to that in terms of the time frame change? I found that very interesting.
Yes, Philip, with the differences in the first and second wave were quite stark, quite obvious. We did have a shorter incubation period in the second wave. Well, we were dealing with the notorious South African variant. In the second wave, what we found was a shorter incubation period, we found a far more contagious virus. The spread was far more quick compared to the initial. We also found a difference in the range of presentation on the first day, or the initial symptoms, more gastroenteritis. We found more abdominal symptoms.
Yeah.
And we also found a far more severe reaction on the 8th day compared to the initial wave. So we had, look, all three for myself pointed towards the spike protein. The only difference in the virus compared to the wild type was a mutation that caused 40 amino acid base pair difference in the spike protein. And that would account for the increase in contagiousness of the virus. It would account for the affinity to ACE receptors in the gut, and it would account for the increase in allergenicity of the viral debris on the 8th day. So we did see a very similar pattern, and we noticed the same with colleagues in India. When they went into their respective second wave, they had the same, a far more contagious virus that caused a difference in presenting symptoms and a far more severe allergic reaction on the 8th day.
And similarly, in terms of the time frames, it was shortened. And so that changes the way how we look at managing the disease. So from your perspective, Carlette, what are you thinking now compared to initially? Or well, let me just put it another way. So initially, what was your protocol based on, and why? And then we'll talk about what you think you would need to change. What was the basic principle in terms of your original protocol?
Pulmonary dysfunction. The primary focus was very, very simple. Keep them off the vent. What do we need to do to minimize the need for mechanically assisted breathing? For two reasons. We didn't know if we would have enough vents, the first issue. And the second was when a patient transitioned to the vent, their survival was perceived at 50-50, so if we could keep them off the vent, we had a better chance of keeping people alive. And so what drove utilization of mechanical ventilation? Pulmonary function, plain and simple, pulmonary function. What was beneficial in a clinical setting, though, is that we saw inflammatory marker detail provide a window of up to 3-day notification of a pending need for mechanical ventilation. In other words, whereas the rest of the world appeared to be chasing oxygenation, O2 sats, if we focused on D-dimer, for instance, we could see elevations in D-dimer act almost as a predictor of the pending decline in oxygenation. Mm-hmm. So if we were given that window of time to say that D-dimer is increasing, and even though D-dimer is an indicator of hypercoagulability, we didn't run to an anticoagulant. We would bolus the corticosteroid. And when we did that, we saw that those inflammatory markers would begin to recover. And once they did, the pulmonary function would improve drastically. And that is what eliminated the need for the inpatient population. I want to focus on outpatient, though, because outpatient, we don't have labs being drawn every 3 days. And, we're not in a clinical setting. And God bless Dr. Shankar for all that he's doing. He doesn't have the benefit of a pure clinical setting. All right. So now what do? Well, we use a pulse oximeter. We just have the fingertip and we put the pulse oximeter there, and we're just looking at O2 sats in that manner. And we were really able to see significant improvement. The steroid priority is methylprednisolone, 16 milligrams daily for 5 days.
So I'm going to pause you on that, because this is an interesting point. And similarly, 16 milligrams daily is what I think they use in India. But Shankara, you go heavyweight. You go with monster doses of steroids. What is the?
Well, I would agree. I would agree. Monster doses are preferred, but we haven't always been able to get the access that we wanted. My preference was 32 milligram, double 16 BID, or a full 32 milligram.
How much would you use, Shankara, and why?
Look, Philip, it changed from wave to wave. The dose of steroid was dependent on the severity of the reaction. If I had to just put the pulmonary phase into a bit of context, on the 8th day, I was of the opinion that we're triggering a hypersensitivity reaction. And if we stop the trigger, we could prevent everything else that followed. So we did, in the patients that I could do labs on, I did see an increase in CRPs, interleukin-6s, which were a good indication that in the 8th day, there was a steep linear or an exponential rise in these values from pre-8th day levels. The dose of steroid was determined by the severity of the reaction. Now, the severity of the reaction had two variables. One was the variant you're actually dealing with. The milder first wave variant didn't require the high dose of steroids. So we're talking minimum effective dose, whereas the second variant required a far higher dose. And of course, it's determined by the patient sensitivity. Some people have severe reactions, some people have milder reactions. Now, we've structured a ladder of treatment based on the reversal of hypoxia. And what I've found is that the drug that reverses hypoxia to the greatest extent is the antihistamines, promethazine. Now, we've seen saturations of 70% improve to 85% without the need for oxygen within 4 hours, and go up to 95% within another 4 or 5 hours. And a lot of people asked me, they said, look, you negated the need for oxygen. How did you manage to do that? If you can get a reversal of hypoxia in such a short space of time, the patient doesn't actually need oxygen.
Right.
Now, the second thing we do, I would give the patient the antihistamine and monitor. If in 4 hours I was getting good benefit, I would add the Montelukast and the aspirin, but I could actually hold off on the steroid because I haven't gotten into the hyperinflammatory phase with this, so I could keep the dosage of steroid lower. So I think as well, if you catch the patient later with a higher CRP and interleukin, you got more inflammation and the dose of steroid needs to be appropriate. And we can't faff around with low doses. We're trying to avoid intubation. So you'd rather start very high, get the turnaround clinically, and then very quickly decrease that steroid. The longer you leave that patient clinically ill, the soup of markers that you're going to get is going to be impossible to get back.
Yeah.
So we're dealing with a trigger of hypersensitivity, which if not treated will lead to hyperinflammation and hypercoagulability. So I found that with antihistamines that we start very quickly on day 8, you can negate the need for other treatment. Yes, I do advocate a steroid in any event, because we don't want a rebound after we withdraw that antihistamine. So yes, if we get good clinical benefit, I do put a patient on a low dose steroid for maybe 3 or 4 days, just to make sure I'm turning off that tap completely.
So Carlette, just hold on a second, Shankar. I just want to hear Carlette's thoughts with regards to the antihistamines, because I remember the first time I heard it as well, I thought, really, that is incredible.
But it makes sense. Mast cells. So I'm very excited to hear about it. I'm so thrilled and honored to even be in your presence. Pharmacologically speaking, I'm so excited. Tell me, what are you able to share your choice of antihistamine and any dosing?
Look, promethazine is my choice. Look, it's the strongest H1 blocker.
Yes, it is.
What we find is, I think what we're dealing with is alveolar edema. That's the initial symptom that causes the desaturation. And if you can reverse that fluid extravasation, you get very quick results. I mean, if a patient presents with a bee sting, we can almost see the reversal of the reaction. And so the promethazine has been my choice. Yes, there's been concerns about its sedation and its use in elderly cardiac patients. However, the sedation can be used to your benefit.
Oh, yes.
A lot of patients come in very anxious at that point. So promethazine is still my gold standard. From the other antihistamines, the levocetirizine has shown benefit. So what I do is I put patients on promethazine for 2 or 3 days. Their oxygen sats rebound very quickly. And then I swap them over to the levocetirizine, a BD dose of 5 milligrams, which is far better tolerated. In my older patients as well, we get a 10 milligram promethazine tablet. And I use that. I prefer to give them the 20 milligrams at night and maybe 10 milligrams morning and midday. But as soon as they have reversal of their hypoxia, we change them back to a milder antihistamine, more prophylactically and protectively. I do add Montelukast. That's vitally important to mop up the leukotrienes as well.
Yes.
And of course, I worry about platelet activating factors. So aspirin and clopidogrel are part of that initial intervention.
So I take it, Carlette, you're impressed with the antihistamines.
Oh, yes. I want to have a parade for him.
We've seen some remarkable results, Carla.
And just to highlight, Carlette, we haven't said this before, earlier in the show, but Dr. Shankara is now speaking across the world on this protocol. You should update us, Shankara, a little bit about this work that you have done in different parts of the world.
Okay, Philip, I was invited by the health secretary in Meghalaya, which is an autonomous state north of India. They invited me to present the protocol to them. We initially discussed with the broadest range of specialists in the country, from the rural doctors to the pediatricians, the obs and gynae, and the intensivists in ICU. The first meeting was about protocols and about how we get public education out. Very quickly, within that 2 weeks, the intensivist came back to me to say, look, using the antihistamine has actually managed to prevent 3 out of 4 intubations in his ICU. He did narrate, they did call me back a few weeks later to train the rural doctors, simply because they found the benefit in ICU could be extended to earlier intervention to prevent the hospitalizations. He did give me a little anecdotal story. His granny was 84 years old, presented to his ICU with 39% sats on day 14. They put her on oxygen, started on the protocol. When I had spoken to him, she was on day 5. Her saturation on room air was now up to 93%, and she was going to be discharged in 2 days. She had comorbidities of diabetes and hypertension as well. So that led them to think that we need to do this a lot earlier so we can prevent the hospitalization. So I had a second meeting with them. They have published a public guideline, public information leaflet explaining all the issues from masking to proning, but highlighted the importance of the 8th day, the hypersensitivity reaction that takes place on that day, and advise patients how to seek medical attention appropriately. So the whole aim was to get patients into the medical setup by the 8th day, so that we could catch this early and be aggressive in our intervention. The second place was in Malaysia. I was invited by the Private Practice Association there to train doctors in the protocol. That seemed to have benefited a lot. We have about 250 odd doctors that we've trained. From around the subcontinent, we invited doctors from the Philippines and Cambodia. We've had a subsequent meeting with the Public Health Minister of Shillong Province. She was very interested in our work. So we are trying to get a government-private partnership going so that we can change protocols to allow patients early access to outpatient treatment. In Malaysia, the norm is to be isolated for 14 days once you turn positive. That precludes you getting any medical care. So after she saw the benefits of what we were doing, she decided that she needs to bring it into her province. And being one of the wealthiest provinces in Malaysia, hopefully it becomes government protocol. Here in South Africa as well, we're getting some benefit. We're doing a clinical trial. The doctors are amazed at the antihistamines and how well they work. They are calling it the first treatment for hypoxia. It's the only drug that's been shown to reverse hypoxia in such a short space of time. And so now we have patients every 4 hours to see the benefits.
Listen, I tell you what, Carlette, when I looked at it after first speaking with Shankara, I realized that this is about mast cell activation.
Yes, absolutely.
This is what is killing people. In the phase where the pulmonary phase happens is first mast cell activation, and if it's left long enough, it then becomes a lung vasculitis with microthrombi.
Yeah.
And so if you don't suppress it early, you are then going to be battling in the hospital phase to keep them off a ventilator. So let's tease out your mind here a minute, Carlette. If you think about what he has just said with regards to what we see happen, is there anything better you could see that would work on that mast cell activation to get even better outcomes? Any thoughts? If you had all the resources.
Right now, when I think of mast cell activation, I think of histamine 1 response. Absolutely. But then I also think about the advent of the leukotriene contribution. So when he brought up Montelukast, I agree with that as well. This is my first time hearing about it, so I don't want to attempt to even organically go very in depth. But from my perspective, I am challenged to see that you wouldn't prioritize the corticosteroid with the inflammatory process in the lung. So when I'm hearing about mast cell activation, and I'm curious about understanding which do you prioritize. So it sounds like you prioritize the antihistamine over the corticosteroid versus the other way around, because when you talk about the viral phase and then the inflammatory phase, it sounds like approaching the 8th day is when you bring the antihistamine on board versus...
Can I clarify that, Carlette? Look, when we talk of the adding of the second line of treatment, from talking to the intensivists here in South Africa, with the use of steroid, they found an improvement in oxygen saturations over a period of about 48 hours. So they noticed a steady, slow increase in it. Now, with the promethazine, you're seeing far greater improvements in a matter of 4 hours. So the second line is not really being deferred. So what we're doing is, there's been a lot of controversy about when to put steroids in. And of course, we're dealing with different variants and different people's sensitivities to these allergens. Yeah. So what we decided we're doing is to use the promethazine and the Montelukast as your initial intervention. Okay. And monitor the patient over that first 4 hours. If you get a drastic improvement in saturations, you caught the patient early in this phase. Yes. And so even if you use steroids, you can temper the dose. Yes. But if you have a slow benefit over that 4 hours, then you're still in a reasonable time frame to start steroids aggressively and deal with with the process that's going to unfold. So when we look at second line, the second line is 4 hours down the line. Yeah. We're just giving the antihistamine 4 hours to see some benefit. And the benefits are quite remarkable. So monitoring that early 4 hour to 6 hour period is vitally important in gauging how we move. So I think intense monitoring of that first 24 hours is critical to turn this around and we don't go any further.
All right. So now if you let me interrupt briefly.
Yes.
4 hours. In a perfect world, we have all the time in the world. But in real life, particularly in the outpatient setting, I can't speak for South Africa, but in the USA, they treat medicine as fast food. All right. So I don't know that a patient in the outpatient setting would come into the clinic and now say, "You want me to wait 4 hours?" I'm not trying to be facetious. I'm just, being honest with you. At least here in this place, I'm not giving you 4 hours. That's the patient is going to say. Say what?
Yes.
So if you have to treat them and street them, so to speak, what would be your approach there? Because for me, and I'm not a physician, I'm a pharmacist. So I'm observing the assessment and the conversion into a treatment plan, and they want me to, render the remedy. There's my opinion. I've garnered some credibility in an opinion.
Okay.
But even if they want the patient to hang around 4 hours, they're not going to do it. I'm just telling you, they're not going to do it.
Look, I never had patients wait that period of time. This is something that's being touted now, seeing that we have hospitals on board and we can monitor patients hour by hour. Okay. In my setting, I saw the recoveries relatively quickly. So patients got sent home. Patients got sent home with a script for a steroid. And I contacted them the first thing in the morning to look at clinical recovery and their saturation recoveries. And if they reported good recoveries, we could withhold. If I noted that the recovery was a little slow, I asked them to initiate the steroid. But I was pushed into a corner in that I had patients traveling from far and wide to come and seek medical attention and refuse to be hospitalized. So I think the worst patient that I had was one with a saturation of 35%, barely conscious. So I've dealt with ICU patients in an outpatient setting. I was forced into that. But of course, I had the experience of the recoveries with antihistamines. So even those patients that presented with such low sats, 50%, 55s, I put them on treatment and I sent them home and contacted them. And I had patients over 2 days return to over 90% without the need for oxygen. Yes. There were a small subset of patients who were critically ill. Now you must remember, I got patients with 50% saturations on day 10, but I had patients with 50% saturations on day 12, and they were developing crepitations. And that's a dangerous sign. So it shows the extravasation of fluid. Now in those patients, I nebulized them with adrenaline, just to reverse that extravasation of fluid. And as soon as I found that their crepitations had settled in my practice, they were free to go home. Some of them needed to go to the local clinic for an hour of oxygen just to give them symptomatic relief the following day. But I haven't had a patient not show a good rebound in saturations within 2 to 3 days.
Now, hold on a second, Carlette. Now, that is proper medicine, eh? I mean, those days of just saying, listen.
Can you believe it? Can you believe it?
I mean, that is how you practice medicine, it's not any of it. How many people in a first world country, if you wrote a prescription for adrenaline nebulizer, would the pharmacist even give?
No. Very good.
So this is why I'm saying that what you did, Shankara, is really fascinating. My question is it possible, even because Shankara had limited resources, and so this is why he got creative. But if he had unlimited resources, how much more could have been done? This is part of the question, meaning that if you had, if the pharmacy was there and you had any drug you wanted at any dose you wanted, how do you manage that? So this is the bit that I think is really fascinating to squeeze out of Shankara and to think outside the box. So say, for instance, nebulized adrenaline. I suspect in a first world country, we would struggle to get that done if they weren't in hospital. Is there anything else that we could use that would work in a similar way in the outpatient setting? But I guess the point is that if you're in a first world country, you would just admit them. If they reach that point, they would just end up being admitted. The problem that, however, becomes very practical, and I want you guys to think about this, is that what we are talking about here is real world experience, but this is not what people get when they go into hospital. And so this is one of the huge challenges, is that even if a patient knew this, because they had heard this and they said, you know, I'm not, give me some nebulized adrenaline, they wouldn't get it. And so,
but I would caution you to focus on, respectfully, what they can get versus what they cannot get. Yes. I have to admit, to hear about nebulized, you say adrenaline, in the US we say epinephrine. No, it's not going to be on the shelf. It doesn't matter whether or not I want to give it. It's not accessible in that manner. But the intent is to breathe, right? Yes. So the first thing that came to my mind was albuterol. It's not epinephrine. It's not. But it would still support bronchial benefit. It would still support bronchial benefit. It is the most widely accessible in the US, and I'm saying in the UK. It's going to be on the shelf. It's going to be on the shelf. Now, his particular patient needed epinephrine.
Yeah.
Right. But there aren't many people who are ordering nebs. I think nebs is what was needed. You know, I shared a personal challenge with my son, Dr. Phillip, and the challenge of him being admitted to the hospital, and their protocol was no treatment until his O2 sats dropped below 90, even though he's a 38-year-old male, height and weight proportionate, college basketball star, you know, everything about him's healthy, no chronic conditions at all. And yet he would have not received any treatment. When I asked professional courtesy to consider the steroid, and the first response the physician gave me was, well, you can't give a steroid with a viral infection because it's immunosuppressive. I said, yes, you're right, but his O2 sats are continuing to drop. His heart rate is 122 and escalating. He can't breathe. He's gasping. Can you do anything to recover his pulmonary dysfunction? No, we wait until they drop a little bit further, closer to 85. So he received no medicinal intervention, and I took a one-way flight to get my kid out of the hospital, and we ended up on CPAP, and with my colleague Dr. Mikowski as the attending remotely, and I was the nurse, vital signs every 4 hours while awake. It was terribly frightening, but you get what you can, and a nebulizer did help him ultimately recover his breath enough for the other medications to begin working. So
this is I want to tease into that there a bit, Carlette, because this is one of the things, because we had spoken some time before, but this really drove you to say, you know what, I need to speak about this outpatient protocol. It was because of your son, wasn't it?
It was absolutely because of my son. And when in speaking with the physician in the emergency department, very kind, very professional, but he stated very clearly there is no documented research supporting outpatient treatment, steroid intervention. There's nothing out there, and because there's nothing official that's been released, you know, patients are hindered in their recovery by the limitations of the medical community. And I have to admit, I had my reservations about hydroxychloroquine as a pharmacist, reservations about ivermectin as a pharmacist. And so to prepare to be insightful in communicating with the group here and for the team, I went to PubMed specifically looking for studies that have been published with ivermectin and COVID-19, some great results, limited group, no one 4,000 patients. But absolutely, I see a value for it. Nevertheless, if it cannot be accepted into traditional application because the primary indication is antiparasitic, you have to work with what can be adopted and promoted.
No,
feel
but hold on. But even before you go any further, I want to capture a thought here, Carlette. You know what it feels like to be the mom, seeing your son sick, and seeing people standing back and saying there is nothing we can do until he gets so sick. When people see that after listening to this conversation, what do they do?
I like the fact that Dr. Shankara has an approach for outpatient treatment that is at least within indication. The Montelukast and the approach to address leukotriene release, the promethazine and the approach that addresses mast cell release, corticosteroid and the proven undeniable benefit to pulmonary function. Move toward what is at least palatable. In first, well, if ivermectin is working, God bless you for moving forward with what you know is working. But at some point, respectfully, we have to accept that the mass adoption of research is an engine that is bigger than our little bitty contribution to the cog in the wheel. And if that is the case, focus on what is within indication in order to support adoption, ready adoption. If Malaysia and South Africa and portions of India are ready to accept the benefits of ivermectin, which appear to be undeniable, move forward with that. Absolutely. Move forward with that. And if the Western world is saying, oh, but the primary indication is for a parasite, I don't know, then leave them be. They will accept leukotriene. I don't mean leave them be. People are dying. People are dying. So this was my 38-year-old son. When I got to Texas, his wife was COVID positive. The 5-year-old was COVID positive. The 6-year-old, the 2-year-old. So I walked into a house full of a family that was very, very sick. And so that Q4 hours while awake was happening with, I had 5 patients.
But you took the risk and took him out of hospital.
Yes.
No, that you see, because of your experience, you can afford to do that and your contacts. But this is what I'm saying. What do you say to a person out? What do they do?
They suffer. And they suffer. And what he said, and I'm not proud to say that. I'm a licensed clinician. I'm not proud to say, and I took my son out of the hospital. That doesn't make me a hero. I had exposure to an approach that other people did not have. You know, I'm not proud of that. And he's 38. Okay, he checked himself out. He recovered enough to where the doctors, said, okay, I'll let you out. He said he had to calm down and think, to breathe enough, because he said he was getting anxious. He was having to count every breath. He said he hadn't slept in 3 days because he said with COVID, you have to think to breathe because it hurts. And I won't go into all of that. I'm sure you've heard all of that. But yes, his question to me, Mom, was, Mom, I feel amazing, but my heart aches. How many people have died needlessly? And how many more will die because they don't know what to do? Yeah.
And this is the question. This is really the question. And even as we're thinking about what's coming, because whichever way we take it, as I said, that even though we're getting protection from vaccination, the evidence is suggestive that up to even a third of people, even fully vaccinated, could still end up with severe disease. We need systems to be able to manage those people where we have a virus that is 4 times more transmissible than the original virus. We're not going to be able to stop this from spreading. And we don't it's outside of, well, I don't even think in the first world countries we have the resources to deal with these numbers. We need to have some degree of understanding about these strategies. How is that done?
Publication of research. That's the only way.
We don't have the time. We're talking about this is probably in a month, you know. I'm not talking about a year down the line. We could be facing this kind of scenario within a month and a half. What do we do?
So the pure answer is research and publications. You're right, but that is time dependent. So the only other alternative, Dr. Phillip, is what you're doing now, that we have a collaboration of peers who are willing to hear the varying approaches, but to be fair to those individuals hearing the varying approaches, depending on the setting, they won't be able to implement without the publication. Now, the greatest limitations is going to be in a hospital setting because of the formal adoption required by committees and by executive boards. However, in the outpatient setting is where the real heroes of COVID will be found, because they have their own kingdom, if you will, within their clinic to apply these varying approaches. The benefit of a group like yours is that you have intelligent people contributing and you have intelligent people hearing. And as long as specifics can be provided in some, private setting, if someone wants to reach out to Dr. Chetty, for instance, and say, can you give me your doses? Because from the pharmacy standpoint, I hate to hear someone say, this drug works and that drug works and you should just use them. Well, no, drugs are dose dependent. Drugs are dose dependent. The dose does matter. The dose will drive the action and the intensity of the action. You have to have the right dose. So you have to have some specifics in the protocol. Research would give those specifics. Otherwise, everything's organic. So organic for me is I have outreach through LinkedIn from Buenos Aires, Argentina, from Bolsonaro, Spain, and from all over the world, all over the country. What do you recommend? And what is the dose? And, text message is not a professional way of sharing a protocol. But have I shared a protocol through text? Yeah, I have. Because at the end of the day, these are lives. Mm-hmm. These are lives. And we have to have the willingness to share and to receive some criticism and some, professional challenge, if you will, and move forward and keep sharing, because we don't have a lot of time. Vaccines are strain dependent. What does that mean? Well, from a pharmacological perspective, no matter how great you say the vaccine is, it's 95% effective. God bless America. That's what we say. Well, God bless South Africa and the UK too. God bless us all. But the vaccine at 95% is for the strain of awareness or the variant of awareness during development. Mm-hmm. As soon as there's a modification to that particular strain, that 95% effectiveness has now dropped to perhaps 90. And now there's a new strain. So conceptually, that the effectiveness has dropped from 90% to 85%. And with every new strain, you have a decreased effectiveness only because this vaccine could only be as strong against the strain of awareness at the time of development. When you think about an outpatient approach, now you're talking about strain irrelevance.
Yes, yeah.
The strain doesn't matter.
Mm-hmm.
How could it? If you defend the body, the strain will have no impact.
Mm-hmm. Yeah.
So the intent should be, pharmacologically, prevent the infection. An ounce of prevention is worth a pound of cure. Mm-hmm. Prevent the infection if you can. If you have a willing recipient of the vaccine. So let's not forget that. We have people who want to avoid being vaccinated for their own personal reason. I won't, make a statement either way about that. For people who wanted to take the vaccine or taking the vaccine, God bless them too. They felt that they needed to prevent this horrible occurrence. But even in preventing it, a third of the people who received vaccine are contracting the virus and even dying in your area, in the UK. So now what? There are people who have not taken it. Again, if you defend the body, the strain becomes irrelevant. Mm-hmm. For those people who have had the vaccine, I would dare say now, you still need to defend the body to cover the percentage that you no longer have effectiveness for. What does that mean? You've taken the vaccine. You believed it was the best effort for you and your family, whether it was a messenger RNA vaccine, I call the synthetic genetic production, or it was the non-messenger RNA, the biologic genetic production, when they culture the same way they make vaccines. So you did whether an mRNA or the non-mRNA, fine. Boost your immune system. That's the pharmacist's recommendation, because that's the best way to cover any of the deficiencies that have occurred because of the strain mutations. Does that make sense? Mm-hmm. So that's my recommendation as a pharmacist. We should all be boosting our immune system, which is our body armor, if you will, to prevent the risk of infection, whether vaccinated or not.
Hmm. And so that raises, as we're coming close to the end now, Shankara, in terms of that prevention strategy, did you have any strategy that you implemented pre-infection that you said to anybody?
Philip, in South Africa, we didn't have the hard lockdowns like the rest of the world. We have a diverse population, and some live in informal settlements where there's absolutely no way to isolate when you test positive. So in the first and second waves, a lot of the infection was left unchecked. With patients that presented positive, they had to isolate with their families. So I asked them to wear masks, do the social distancing, keep away. But I did use doxycycline with all patients from day one. And I found that infected patients did not transmit the virus that easily to other family members that were living with them with the use of that doxycycline. So it became very quickly standard of care in the first 7 days to try and prevent that infection from spreading. Subsequently, the blood services has done some antibody assays, and what they found was that 64% of the population who had no previous COVID illness record had antibodies amongst the Black population. Now, this is the population it spread through the quickest in the first wave. So it showed a reaching of herd immunity amongst that population. And we did see that in the second wave, I had far fewer Black patients affected. It mostly affected the Indian population, who seemed to have had the ability to isolate in the first wave, but left their guard down once lockdowns were lifted. And so I would have expected a widespread in the second wave, but I found more Indian patients compared to the first wave. And Black patients seem to be reaching herd immunity. Now, there are studies that are showing us the long-term immune response to coronavirus, T-cell responses. So I'm hopeful that even without the vaccines in South Africa, we will get towards herd immunity, and that will protect us. As far as avoiding the virus itself, unfortunately, in the country we live in, we haven't really had any hard lockdowns, and it's business as usual. People are wearing masks, people are socially distancing, but if you look out the window, it's like any other day. So from a point of view of hard lockdowns, isolating people, trying to catch the virus, I think we're looking at a different approach. You know, my biggest concern was that the PCR tests were not very specific. So we would not isolate everyone we wanted to. if we did not test a large proportion of the population on almost a daily basis, then we're not going to find the virus and isolate it, if that was our intention. And so I think the hard lockdowns and things need to get re-looked at and see whether it does have a benefit in the long term. Also in view of its damage to the economy and jobs and all that kind of thing.
Yeah, great stuff. So as we come towards the end, Carlette, any thoughts that you would want to share based on our conversation and that you think that the public should hear about? Are you there, Carlette? Have we lost Carlette for a minute? Whilst we wait on Carlette, Shankar, why don't we say for you, in terms of the way forward, where we're going to go from here, what are your thoughts? Not so much just in South Africa, but with what you see across the world.
Philip, there's a lot of early outpatient treatment protocols out there, and they all coalesce around the same biphasic nature of this illness. So I think what we need to do is get all the players together, understand the pathogenesis we speak of, and we can coalesce all these treatment strategies into one protocol that addresses all the different facets that have been noted by different outpatient players. And I think that will give us the traction to move ahead in unison. We need to also break the disconnect between outpatient and inpatient treatment. So we need hospitalized patients to be, or doctors in hospitals to be embracing the same strategy of treatment. I think that's the most vital thing from a treatment perspective. As far as the influences are concerned, I think governments and governing bodies need to come to the party as well and need to listen to the clinicians on the ground.
Wow. Yes, I mean, I think we've temporarily lost Carlette. I would have liked to hear her final thoughts on what we had said. So if she jumps back in another minute or so, we'll certainly be able to hear her thoughts. But I think that, Shankara, all I can say is that your work, your clinical work with regards to COVID-19 has brought tremendous benefit to people around the world. Most importantly, I think that it has given hope that there are solutions, that we don't have to be as anxious in terms of how we manage this disease, even in the context of a Delta variant. And this is the bit that we have. And we've got back Carlette. I just wanted to hear your final words, Carlette, in terms of what you thought of what we've been saying and where you think this is going to go.
I think that the approach to treat COVID formally with an outpatient protocol is no longer an option. It is a must-do to save lives. And where we should go from here, I would like to see forums such as this continue to move forward. But then for those who are listening, if they are outpatient providers, practitioners, I'd like to see them become activated and taking what they're hearing and putting it into action. Lives depend on it.
Yeah, absolutely. Absolutely. So thank you very much, lady and gentlemen. I have had another wonderful conversation and I really appreciate you all. So hang fire with me while we do this outro video, and thank you very much for everyone who is listening. Until we meet again, which will probably be Saturday for our first conference on upper airway strategies in COVID-19. Look out for that as well. Have a great day, everyone.
Thank you for having me.